So I request all the speakers to come on dais. Dr. Atul, Dr. Ganga Khedkar, uh, Dr. Jyotidhar also is there, I think, if she can also join with us.
We need
Jyoti.
two chairs.
Yesterday, and I envy her commitment to science.
Hello.
Her bag was put in taxi, and her mother-in-law was not having pulse. So she calls me, my mother-in-law has no pulse, should I come or what do I do? And her husband tells, you go ahead. I said, no, you cannot come, you just finish that. And within 1 hour, her mother-in-law died. So I really applaud her presence, and we would have greatly missed her if she was not there.
So any questions from the audience about the talks? There's a reminder about compartmentalization of HIV, late presentation, treatment of older populations, and drug-drug interactions. Please.
Good afternoon. My question to Dr. Atul Patel, sir. Sir, do we, resistant testing of CNS viral load is possible or not? And do we require it when we see that plasma viral load is undetectable and CNS load is high?
Yeah, this is a very good question, and recently we have tried to look at the resistance in the CNS compartment, and we have couriered 2 samples to Dr. Ganga Khedkar at Nari, and just waiting for results. But absolutely yes, like whenever you have a controlled disease into the peripheral compartment and you have very high CSF viral load, you have to look at the resistance inside the compartment, and you need to adjust the dosage. Though we do not have great information that the adjusting dosage can improve the neurocognitive abnormalities, but yes, we should do it, and probably that will help to a patient. So whatever experience that we have in adjusting the dose, the antiretroviral drugs and the dosage, when somebody has a controlled peripheral disease and breakthrough in the CSF compartment, most of the patients, they have rapid improvement in their the HIV-associated neurocognitive disturbances. So even though we do not have a great the information that adjusting the drug by CPE score will help in reducing the neurocognitive, but when somebody has the symptoms, and once you adjust according to the CPE, it will definitely improve the neurocognitive abnormalities.
So, which are the best ART for kind of the cases?
The zidovudine, nevirapine, and ritonavir boosted indinavir has the highest penetration.
Good afternoon. This is once again to Dr. Atul Patel. You have explained the reservoirs in various tissues very excellently. I am having a doubt. In future, if we are having drugs to eliminate the reservoir or purging the virus, will it affect differently in various tissues? So HDAC inhibitors, they may likely to come, or urinostat, they may likely to come. Even in that condition, even that is a reservoirs in gut, reservoirs in CNS system will behave differently or same. That's what my question.
That means you want presentation of CNS HIV viral load viruses, or what do you want actually?
No. To eliminate the reservoirs or to eliminate the virus from the reservoirs, the drugs in future, will it behave same with the all tissues or with differently with different tissues?
So you want me to say about elimination of the virus from the
future,
reservoir?
In future.
In future. Yeah, I am not a right person, but I think Ganga Khedkar can answer this about reservoir and the elimination strategy that he is working on.
No, perhaps we could wait for that question tomorrow.
Thank you.
No, otherwise.
Maybe I can ask a question about late presentation. One aspect of that is diagnosing patients early and then seeing them grow older, and I think that's very important. We're all seeing it. Another is having people either infected or diagnosed very, very late. The eventual result is maybe the same, but maybe there is a specific considerations to be made on the second group. I was wondering if you had any information about this from India and whether there should be any considerations on that.
I don't have any information about that from India, but I can say from UK, we do have a percentage, which is not very high, and as we can, these are patients in UK, it's very different setting, and these are patients who are regularly testing, so they would have had something like 20 negative tests before they tested positive. So we know when somebody tested positive when they're 65 years of age, and they had previous negative tests, we certainly can be very sure that's a new infection at that age, and not somebody who had the infection for 20 years and we are just picking them up. So that way, I think we have those information. Thank you.
Other questions from the audience?
If it is not there, we conclude the sessions and request organizers to felicitate.
I request the chairpersons to kindly felicitate the speakers. Dr. Amar Pazare to Dr. Atul Patel. Dr. Jyoti Dhar. Dr. Cantor to Dr. Usha Natarajan. Dr. Cantor to Dr. Jaideep Gopte.